Welcome to the Stat AI podcast.
Welcome to the future of emergency medicine, a realm where artificial intelligence isn't just a buzzword, but a beacon of hope and a tool for transformation. I'm DJ Apakama. My co-host Ethan Abbott and I are both emergency physicians, and we have witnessed firsthand the burgeoning role of AI in our field. Our everyday experience grappling with healthcare disparities and social challenges have led us to a pivotal question. In the wave of AI applications, what changes are coming to emergency medicine, and will they be for the better? This podcast was born not just to ask these critical questions, but to seek out answers from the experts, to understand and demystify the potential of AI in emergency medicine. We believe in bringing this conversation to the wider community to embrace AI as a tool for positive change. This podcast is our exploration of that future, a journey we invite you to join. So let's embark on this path together to learn, to question, and to envision a new era of emergency medicine enhanced by the power of AI.
On this episode of the Stat AI podcast,
I do think there's a real unique opportunity to have chatbot-oriented interfaces for data collection, to leverage the fact that patients are in the emergency department for multiple hours, and to help do screening and other things in that space.
Welcome back to the Stat AI podcast. I'm DJ Apakama.
And I'm Ethan Abbott, and today we're diving into something that made me do a double take when I first read the title.
Oh, you mean an electrocardiogram foundation model built over 10 million recordings? That's not your typical Tuesday research paper. When I saw that number, 10 million ECGs, I had to check if there was a typo.
Right, and I think this isn't really just some academic exercise. This is from the NEJM AI journal, and this particular publication was published last month. And it represents what might be the largest ECG foundation model ever created. We're talking about ECG Founder, a study led by Dr. Shenda Hong from Peking University and a senior author, Dr. Gary Clifford from Emory, both powerhouses in biomedical AI. And before our listeners roll their eyes at another tech name, this thing actually works.
Let's put this in perspective for our audience, Ethan. In your typical shift, how many ECGs do you read?
On a busy day, maybe 15, 20. 30, it could be even more. Signing EKGs for other areas of the department requires focus, pattern recognition, years of training to interpret correctly. Now imagine having an AI model that's seen 10.7 million ECGs and can diagnose 150 different cardiac abnormalities.
Yeah, that's what caught my attention immediately. The scale here is unprecedented. The Harvard Emory ECG database contains recordings from over 1.8 million unique patients. But what really impressed me wasn't just the size, it's how they tackled one of the biggest problems we face in emergency medicine.
Which is?
Picture this, it's 2, 3, 4 a.m. You got a 78-year-old woman brought in by EMS for chest pain. She's confused, can't give you a good history, and you're working with limited information. This model was actually trained to handle these exact scenarios using what they call positive unlabeled learning.
Okay, let me break that down for our listeners. Positive unlabeled learning. Here's essentially what it means. Traditionally, when you train an AI model, you tell it this ECG shows atrial fibrillation or this ECG is, quote, normal. But in real clinical practice, a cardiology might only label the most obvious findings. They might not mention every single abnormality they see. The model had to learn that just because something isn't explicitly labeled doesn't mean it's not there.
Exactly. Here's a clinical scenario where this matters. Imagine you're seeing that same confused 78-year-old. Her ECG might show some subtle signs of an old inferior MI that the original reading cardiologist didn't mention because they were focused on ruling out acute changes, which is what we're usually asking for in the moment. But this AI model actually learned to pick up on those patterns even when they weren't explicitly labeled in the training data.
That's brilliant because it mirrors real clinical practice. We don't always document every minor finding, especially when we're focused on the acute issue, which is more relevant for emergency medicine and what's bringing the patient into the emergency department.
So here's where it gets really interesting for emergency medicine, was that they didn't just build this for 12 lead ECGs. They specifically trained it to work with single lead ECGs too. Think Apple Watches, handheld devices, or the portable monitors that EMS uses.
Now that's a game changer. Let me paint a picture. A 55-year-old construction worker calls at 911 for chest pain. A paramedic puts on a single lead monitor, and with seconds, they have an AI-assisted interpretation suggesting possible myocardial infarction or ACS. That information gets transmitted to RED before the patient arrives. We can activate the cath lab, call cardiology, get the team ready.
Yeah, and the performance numbers were pretty impressive. On the internal validation, they achieved over 95% accuracy. We call this area under the receiver operating characteristic curve, or AROC for short, for 80 different diagnoses. When they compared it to actual cardiologists on a committee test set, the model achieved better overall diagnostic accuracy.
Wait, let me make sure I heard that right. The AI outperformed cardiologists?
Well, in this specific test, yes. But here's what I think is important to emphasize. This isn't about replacing cardiologists or emergency physicians. Think of it like having a really smart resident who's seen millions of ECGs standing at your shoulder, pointing out patterns you might miss when you're managing 6 patients simultaneously.
Right, and that brings up something that we talk about a lot on this podcast, the human AI collaboration. What I found fascinating is how they handled what they called leads augmentation for single lead ECGs.
Yeah, so for our listeners who might not be as familiar with ECG interpretation, let me explain this with an analogy. A 12-lead ECG gives us 12 different views of the heart's electrical activity. It's like having 12 different camera angles of the same basketball, football, soccer, baseball game. A single lead EKG is like having just one camera angle, but if you understand the relationship between those angles, you can infer quite a bit about what the other angles might be showing.
And that's exactly what this model learned to do. They trained it by taking the 12 lead data and showing the model how different leads relate to each other, especially around the heart's electrical axis, basically the main direction of electrical flow through the heart.
Yeah, so now let's talk about my favorite subject, equity and bias, because this is crucial. The authors were honest about a significant limitation. This model was primarily trained on U.S. data, predominantly from 2 major academic medical centers.
And that's a big deal. Different ethnic groups can have different baseline ECG patterns. For example, early repolarization, which can look like ST elevation, is more common in young Black men and is usually benign. But if your AI was primarily trained on data from other populations, it might misinterpret these normal variants as pathological.
Exactly. And this gets to a broader equity issue we see in AI development. If the training data doesn't represent the full diversity of the patients we see, different races, ethnicities, ages, underlying conditions, then the AI might perform worse for those underrepresented groups. That could actually worsen healthcare disparities rather than improve them in the long run.
And the authors acknowledged this limitation in the paper, which I really do appreciate. They also noted that their external validation included data from Brazil and Germany, which helps, but we still need to be thoughtful about how we implement these tools to ensure they work fairly for all of our patients.
Okay, let's get practical for a moment. They did some really interesting downstream applications. They fine-tuned the model to predict things like chronic kidney disease, heart failure markers, specifically something called NT-proBNP, and even demographic information like age and sex from ECGs.
That NT-proBNP prediction is particularly interesting for us in emergency medicine. The NT-proBNP might have a different name at your institution, but is a blood test that helps us think about heart failure on the differential diagnosis, but it can take an hour or more to get the results. So imagine this hypothetical scenario where a 68-year-old comes in with shortness of breath. You're not sure if it's heart failure, pneumonia, maybe a primary lung etiology such as COPD. If the AI can give you a preliminary heart failure risk assessment just from the ECG waveform while you're waiting for labs, that could really help with early treatment decisions.
Yeah, what I found most impressive was their external validation approach. They validated it against 3 completely different data sets from different countries and healthcare systems, and it did perform well across all of them.
And I think that level of validation is what gives me confidence that this isn't just another overfitted model or a study that's using synthetic data, and that it works great in a lab and could fail in the real world. This is really stress testing the model in the clinical environment. This is what we want to see with the future of these technologies.
Yeah, well, all right. I think we did enough hyping here. Before our listeners get too excited and start asking when they can download this for their phones, let's talk about the kind of deployment reality here. The author specifically mentioned that ECG Founder runs on cloud-based systems, not directly on wearable devices. So we're talking about devices that capture ECG data and then upload it to the cloud for analysis.
These foundation models are massive, millions of computational parameters. Your Apple Watch isn't able to run this locally anytime soon. But that cloud-based approach opens up other possibilities, such as integration with electronic health record systems, where the AI interpretation appears alongside the ECG automatically? For example, if you have clinical decision support tools embedded into your EHR.
Yeah, and I think that probably cuts both ways. That's obviously a security issue, but the authors made their model, code, and training data publicly available, which I think is fantastic for advancing the field. Too often we see these impressive AI research that kind of gets locked away in proprietary systems. So it's nice to see that they were able to take a different approach.
And I think that is highly relevant and brings us to our guest this week, Dr. Andrew Taylor, who's a professor of emergency medicine at UVA. And he had moved from Yale earlier this year and has been doing some fascinating work on AI applications in emergency medicine, particularly around clinical decision support systems and how we can thoughtfully integrate AI tools into emergency department workflows while addressing equity and implementation challenges.
Yeah, I'm excited to get his perspective on foundational models like ECG Founder and how they might fit into a broader landscape of AI in emergency medicine. He's been thinking deeply about the practical and ethical considerations of deploying them in high-stakes clinical environments.
Because while the technical achievements in this ECG Foundation model are impressive, the real question for us, I think, as emergency physicians is, how do we responsibly integrate these tools into patient care? How do we maintain that critical thinking and clinical judgment while leveraging AI to enhance our diagnostic capabilities? And lastly, how do we ensure these tools help all of our patients equitably?
These are the kinds of questions that get to the heart of what the podcast is about, not just celebrating cool AI research, but really examining how these technologies can improve emergency medicine practice while keeping patients safe and equity at the center.
So stick around for our conversation with Dr. Taylor. We'll be diving deep into these questions and exploring his vision for the future of AI-assisted emergency medicine.
Yeah, thanks for listening to the Stat AI podcast. We'll be right back after this with Dr. Andrew Taylor.
All right. Today we're talking to Dr. Andrew Taylor, Professor of Emergency Medicine and Vice Chair of Research and Innovation at UVA.
Welcome, Andrew. We're excited to have you on the podcast.
Great to be on.
Awesome. So I think we wanted to start off talking about your personal journey and you came from and where you're going. If you want to go back as far as you'd like, maybe not from birth, but at least start maybe, I don't know, undergraduate. I know you have a background in physics, and talk a little bit about what got you to UVA and what got you involved in this whole tidal wave of artificial intelligence and emergency medicine.
Yeah, and actually the physics has a tie-in on several different places. So I'll start with where I ended up at Yale after emergency medicine residency. I came to Yale for an ultrasound fellowship. Shortly after starting ultrasound fellowship, I realized I really liked research. We were starting to get electronic health record at the time, converting over to Epic. And I just realized that there was going to be just mountains of data that were going to be potentially available to do various types of research in that space. It aligned with more of my data analytic and data science background. This is where the tie-in to physics and ultrasound comes in. This was the period where Jeff Hinton, the group from Toronto, were coming out with their convolutional neural nets and GPU hardware they've been able to utilize to really, I think, push the kind of computer vision space forward significantly. I think if you look at like kind of watershed moments in kind of AI, that was probably one of them. So I started thinking about types of applications, mainly from an ultrasound standpoint. We started looking into that and exploring other applications and using electronic health records, because at the time it was really difficult to do computer vision research. Like first you have to have GPUs. We had to purchase those. Even then, it was pretty difficult to get into the space, but it was a lot easier to utilize electronic health records. So I started doing that. Yale at the time had this interesting program, which is a master's in health sciences program, and it allowed me to take additional classes. I love to tell students that there was not actually a master's in data science program in the country at that time, which is kind of crazy now because at UVA now we have a school of data science and there's probably 100 or 200 data science programs, if not more, across the country. But it's like, in only a 12-year time frame, a rapid change. I started doing a lot of electronic health record, informatics, data science research, and started building out models kind of from machine learning standpoint. And at the time, it was also very difficult to get those models into the systems. We were building models and kind of showing their effectiveness in comparison to kind of traditional approaches, but it took several years to start moving those models into practice. I got entrenched in informatics, data science, and AI. That eventually led me to shifting and moving from Yale and coming to UVA to really kind of push kind of digital health and AI applications forward. That's where I am currently.
Yeah, amazing. I feel like that was a pretty good summation of really 10 years. It just seems like everything is moving so fast. Thank you for taking us through it. I wonder, for a clinician who's listening post-shift, how do you define simply AI in the ED? Is it what we're getting at the top of our EKG, or is it, going to kind of like an open evidence types, getting clinical decision support? What do you actually think as?
Yeah, I honestly think it's getting really difficult to come up with a standard definition to AI. I think probably all of those at some point would have been defined as AI. I tend to group it into kind of an application domain, thinking about AI from that perspective. When we're doing predictive analytics and we're using lots of features available in the electronic health record to make some prediction, whether that's for diagnosis or prognosis or some downstream event, a lot of that's going to be considered AI. And the thing to realize for a lot of listeners is the term AI has been around for a very long time. Since the 1950s, there were a couple of AI winters that people reference. After the second winter that happened, that the term dropped off and people would frequently use machine learning. That was the term that we used from like in the 2013 up until probably 2022 when ChatGPT kind of started, and then everybody started using the term AI again. It became acceptable from a grant standpoint and everything else. I don't like the term artificial intelligence. I think in general, we would view it as intelligence in the sense that it's able to make decisions with the available data that tend to parallel what we have traditionally defined as intelligence within humans. And that can have many shapes and forms. Predictive analytics would be one. Most people are now familiar with chat interfaces and working with AI in that space. But then there's a lot of going on operationally in the background that people don't see. Automation processes are happening in healthcare spaces. I think probably the one that people are most familiar with would be clinical billing components, where systems are moving into AI applications in that space.
That's great. We wanted to ask you something adjacent to that question. How do we separate out the press release AI hype that seems to be pervasive now and the idea that AI is the ultimate game changer? Some of your research supports that idea, but how do we separate that hype from what actually could help or is helping in the AI space within the emergency department setting specifically?
Yeah, I mean, the first thing they realize, I think a lot of times people, when they talk about AI, they tend to look at performance. So that may be the traditional way would describe it as accuracy. There's obviously a lot of metrics that go into describing performance of AI. I think the way to get around the hype of AI in these settings is to look at patient-oriented outcomes or physician-oriented outcomes or whoever a tool is directed towards and what outcomes are important to them. This is very similar to what we initially saw in the digital health app space. Healthy lifestyles, glucose monitoring. It was a wild west. There wasn't a lot of FDA regulation around those tools, and everybody was promising everything, but there was nothing really supporting from a scientific standpoint a lot of the claims being made. I feel like this is maybe a limitation of the current healthcare environment in that a lot of these AI startups struggle to get effective partnerships where they can examine their tools in clinical spaces and actually look at outcomes. If they have a particular viewpoint, can they get into a space and saturate that space with their product? But it's been somewhat limiting. I think now we're starting to see some movement with randomized controlled trials with AI products, but that has been multiple years coming to that particular kind of, for sure.
Yeah, I think that dovetails right into the recent study you had in the New England Journal of Medicine AI, which was titled Impact of Artificial Intelligence-Based Triage Decision Support on Emergency Department Care. One of the things you just mentioned that I think makes this a good segue is that you guys are actually testing an AI application in the ED, not using synthetic data or vignettes. Take us through that.
Thank you.
Yeah.
Thank you.
Can you take us through, describe the study and the implications that you were taking away?
Sure. So this was in partnership with a industry partner. The Beckman Coulter is the company name. The product is called Triage Go. Triage Go was a spinoff from Johns Hopkins from ED people at that point, and they had sold their company to Beckman. The study itself was an implementation of Triage Go, and I'll describe that in a minute, at 3 emergency sites within the Yale New Haven Health System. Those were staggered, so you can think of it as a stepped wedge type design. The reason they were staggered was because there's a lot of implementation aspects, particularly a lot of detailing around nursing and getting the end users, which are nurses, used to a product. It is a big change in their workflow. Actual tool itself is a triage tool. So if you think about, emergency severity index, it's on 1 through 5 scale, and we kind of know the typical algorithm that goes based on, acuity, but then also resource allocation. So this tool kind of changes that modality and starts to think about triage from the pure sense of patient acuity. The way it does that is the tool is trained to predict several different outcomes for patients downstream. So it's trained to predict whether they're going to go to the ICU within 24 hours, whether they're going to have an emergency surgery within 24 hours, or whether they're going to be admitted to the hospital, with admission to the hospital being the predominant form that the prediction is based off of. The interesting thing is you could do that, and then when you think about design, they could have built a product and then had a predicted probability of each of those outcomes and tried to show that to the user. I think the nice thing is that those probabilities are translated back into the 1 through 5 score that nursing is very familiar with. User standpoint, nursing they'll see a display with a kind of AI tool recommendation about the triage score, the same 1 through 5 score, and they'll also see a textual display about what is going on behind the hood and why that prediction is being made, whether that's because of vital sign abnormalities or past medical history and so on. And then nursing has an option to either accept the score that's recommended, or they could change to that score that ultimately is the final ESI score. One of the main things to realize about triage is that for most sites, you see this build up in the queue around people that are triage level 3. That then causes a lot of related flow issues and also leaves a lot of patients that are fairly undifferentiated in that large category sitting in waiting rooms. This was meant to really push patients into a broader distribution across the 5 categories and get people assigned based on their acuity and those downstream outcomes. What we saw when we implemented this across the sites was some acceleration in operational metrics. We saw what I would call a kind of a validity aspect to the triage scores itself, clearly shifting people that had vital signs and other parameters that would have put them in triage level 3. We were shifting them into a 2 if they were significantly abnormal. If they weren't very abnormal, we were shifting those people into 4s and 5s. We saw better alignment of the actual scores with the underlying acuity aspect of things. So we saw these operational changes. We did some further examination into some cardiac outcomes, how fast people were getting cardiac caths and things like that. Downstream from that, the tool seemed to accelerate those types of outcomes. And then interesting, a fairness or equity aspect. We definitely saw better alignment of the scores with the perceived acuity post-implementation with the AI tool across different demographic groups as well, which I think was very interesting. I think it's a whole different conversation about AI has for a long time gotten a bad rap for potentially, I think, propagating biases in the system, but I think there are real opportunities for it actually to kind of promote fairness and reduce biases within systems as well.
Absolutely. It's a tool, can be used either way, right?
Yes.
Yeah. Are there any particular instances where you spoke with nurses or anybody within the research team where they felt that the model nudged them to up triage? Were there scenarios that made you think about how the system worked effectively, or maybe not, or potential pitfalls with it?
Yeah, I can't emphasize enough, I think, the importance of doing a lot of detailing initially and a lot of education when it comes to whoever the end user is that's going to be facing the tool. One of the things we noticed in one of the community sites was that the tool was putting patients with testicular pain in lower acuity categories. It was taking people that normally would have been triaged at 2 or 3 in the kind of more traditional kind of nursing model and putting them at 4s and 5s. It's developed. Makes a lot of sense, right? The vast majority of people with testicular pain don't end up having testicular torsion or anything that would get them admitted to the hospital or have emergency surgery. It's just very low incidence that they're going to have those types of things. But our medical director at the community hospital did not feel comfortable with those people being changed over into a 4 or 5, that scenario. The nice thing about this tool, and I think this is a good lesson for AI development in general, is you need to have some flexibility within the system to accommodate different variations in process or people's perspectives. And so we were able, for those particular cases, to change the actual rule underneath the tool to say, if they have testicular pain, we're not going to classify them according to this. We're going to move them into a lower acuity, like a 2 or 3 kind of classification for that. So there was a few cases based on chief complaints where there had to be some shifts around. The other thing that was really interesting was that we saw a lot of people that traditionally, almost everybody that was a chest pain patient would have been classified as a 2 or 3 in our system. The vast majority of these people are going home. They're not going to ICU and they're not going into emergency surgery. And so there was a shift for those patients to move to triage level 4s. That required some education across the board, both at the nursing level and then even at the kind of attending level, because they, weren't used to the fact that these patients being at a triage level 4.
It's so interesting because I feel like triage nurses have such sharp intuition and are pretty good at their craft. You already said this was a change to their workflow. I wonder how they internalize that. I imagine some resistant. How do you overcome that when you're instituting a new model that we know is going to be a change?
Yeah, and this goes back to education, detailing, and everything else. One way to change it is to show cases where there was a disagreement between them and the tool, and then what the downstream events were afterwards. That was to help guide. This is one of the things where we have to acknowledge that this is, in this particular circumstance, this is really like a partnership between the tool and the nurse. There are times when the tool is not right because it's not getting some information. The tool is not taking all of the notes and the context and the way they look into account. Nursing is able to do those types of things. And so there are going to be things that nursing is going to be able to pick up on that are going to allow them to more effectively triage patients in some scenarios. And then sometimes the tool is just going to pick up on things that nursing otherwise wouldn't be able to. I think the balanced approach in this kind of human AI combination is particularly interesting. After the study, I think probably the most questions that we got in this domain was kind of further people very interested in that human AI relationship, where are the discrepancies happening, what may be factors driving that. And that's something we're looking at right now. I'm super interested in are disagreements happening when the nurse is on their 11th hour of their shift, or do they just tend to default more to the AI when they're tired? If the emergency department is super busy and there's a huge queue in the waiting room, how do they balance that? Are they changing the way they're triaging based upon that? That's something we're studying right now, and I think is a super interesting area for really kind of all of AI research when it comes to healthcare in the near-term future.
That's great. Yeah, I think you answered a few of the questions we had in mind about bias and human in the loop. I guess one of the questions that comes up a lot is, who do you think is sort of at fault? If the nurse, or I guess it wouldn't necessarily be a physician in triage, but maybe some institutions have that. But who would be at fault if you ignore the AI and there's a bad outcome? Did you think about that? Maybe that was in the article you published, but was that a consideration? And how do you mitigate or deal with those outcomes?
Yeah, this is a super interesting question. Honestly, don't think we've really solved it on a national legal policy aspect. Ultimately, where does some of the burden lie? My general feeling is that as we become more reliant on these types of tools, we have to pass some of the responsibility of kind of performance and outcomes onto the AI companies developing these tools. Right now, if you ask legally, they weren't aware of any current lawsuits pushing this, going after a company. I do think we're going to start to see those things moving forward. Most of the time, the responsibility relies on whoever the clinician was and whatever capacity they were. So whether it was the nurse or a different type of tool or application, whether it was the physician or whoever. I just don't know if that's not sustainable long-term for these things. I think we have to come up with a different approach moving forward.
Yeah, I think it's a really challenging question also because if you look at the chain of events or even the chain of thought with some of these things, it's hard to know, especially with human in the loop. Do you look at where was the error in the algorithm and then where did the humans intervene in that space? And so, yeah, I think it's almost impossible to answer at this point. I do think it's something that each specialty will have to grapple with. I know radiology has been using these tools for quite a long time, and the implications of bad outcomes for a misread on a CT or an X-ray could be problematic. So yeah, I think it's certainly a work in progress.
And I think everything's moving so fast right now. The speed seems kind of breathtaking at some times. But then you turn into the hospital and it seems like that progress is moving a little bit less fast. And I think that's probably appropriate given all the things we've already discussed about. You could have your way, what does a day-to-day in the near future, what does a day-to-day cooperation with an AI look like? What does a human AI partnership in the ED actually mean?
I think there are a couple of areas where I think there are real opportunities. So one, in the emergency department, there's a significant burden of nursing and clinicians from a data collection standpoint about patients. We do a ton of you call, public health type screening in the emergency department, recognizing that we're in a boarding crisis and emergency department is continually busy. It's not the best place to do that type of screening, but we're the front line, and that's where we see a lot of patients that are not being seen otherwise. So I do think there's a real unique opportunity to have chatbot-oriented interfaces for data collection to leverage the fact that patients are in the emergency department for multiple hours and to help do screening and other things in that space. You could think about applications downstream from the initial intake process for patients, like providing better explanation around results they're receiving, enhancing discharge instructions and follow-up information. And then on the physician side of things, there's definitely a need to do better information synthesis and summarization, augment our decision-making. That's something I struggle with. You see a patient, they have to find 10 pieces of information that are potentially relevant, like a chest pain patient. You're trying to find their last cath report or echo, and something's buried somewhere else. There's no context around their past medical history or medications. I think AI has a real opportunity to help synthesize and present that type of information. And then the second part would be providing additional clinical decision support, helping with diagnosis and things like that. And then ultimately, I think with prognosis, because as you all know, one of the biggest steps we take is whether to send a patient home or not. And so continuing to get better understanding around that and what factors are driving that and having AI systems help with that. I agree. Currently, we're just getting started. The healthcare space is probably notorious for not moving as quickly as some other fields. If you look at business and other spaces, they're light years ahead of us when it comes to AI applications and deployments at this point.
Yeah, that is so true. I feel like we are definitely moving at glacial speed sometimes compared to the business world. I wanted to pivot to a question regarding medical centers or hospitals that aren't associated with large academic institutions that don't have huge budgets. I mean, there's been a enormous consolidation of healthcare, over the last 25 years. So there aren't that many community, rural, or safety net hospitals left in the U.S. But those that don't have multi-million-dollar budgets to test and implement some of these AI tools, what would you recommend to a medical director or a department chair of a small site that's not associated with a large academic center? What would be the approach to bring some of these tools in a cost-effective way?
Yeah, I think the first thing is being really strict on what tools you are bringing, what choices you're making, and where you really see a potential benefit. And I'm going to be the first to admit, sometimes that the AI tools aren't going to be the really kind of sexy ones that we would love to see on a patient outcome standpoint. It may be on the administrative side to help streamline that. And that's a lot easier from an implementation standpoint to get those types of tools into systems. I think long-term, I do worry about this kind of AI implementation gap that's probably going to get worse when it comes to comparing academic and large centers versus small rural hospitals. A lot of people are rightly concerned about AI bias. If you really think about it, the biggest potential for bias moving forward is that patients just don't have access to AI systems. The equivalent thing I like to compare it to is thinking about food deserts. If you think about rural areas and having adequate food, I think we're going to probably see something similar unless we develop some frameworks that allow hospital systems to implement AI developed elsewhere and do it cheaply. That's probably going to require some type of universal middle layer where you have a platform that interfaces and it's standardized so it's easy to adopt the tools. Now, the problem is trying to overcome some of the, they're still going to be faced with receiving AI products that have been developed on probably different populations of patients. And so I think you're going to have to be careful about those types of things. At least if you have an appropriate middle layer, you'll have the right infrastructure to do monitoring and everything else. But it's going to be challenging. I'm not really sure of the right solution at this point.
I think that's fair. That might be truly an unsolvable problem. It's also a global issue, right? We're here in the United States, blessed with a lot of compute and resources, but many countries are being left out of this AI boom right now. So I think that problem's going to have to be solved at multiple scales and maybe even simultaneously, but we'll see. I think maybe to bring us to a more light topic, the real reason we do what we do, emergency medicine education and the residents. I wonder, because I grew up in a time where it was novel to have free open access to medical education, PhoMed. Now I wonder how things are changing with AI. If I were doing it again, how would I change how I learned? I wonder if you're thinking about that for your system. How do we bring up today's learners to be kind of AI first or AI native and understand when to use AI and maybe more importantly, when not?
This is a big topic. I think that AI and med is a real interesting space. One, and I think you all have mentioned this already, is how fast AI is moving. I was just at a conference and there was a lot of discussion around diagnostic reasoning, medical reasoning, and using AI as a tool component. Some of the questions came up, well, if you start this kind of training pathway, what happens in 3 or 4 years when AI is much better from a diagnostic and medical reasoning standpoint? What does that look like? What does that mean for medical training and education? It's almost an existential question. I tend to lean in this space thinking that there does need to be some shift in medical education to recognize that we provide as humans that are somewhat divorced from the intelligence component. We have lived a life, we have a particular context. There's that embodied aspect of interacting with patients, those parts of things, that skill set of empathic care that's very kind of, I think, probably lost to some degree, the humanistic aspect of things. I think we've tended to boil things down into diagnosis and testing. Yeah, I think we're going to need to see a much greater shift moving forward to that type of medical education. There are massive amounts of opportunities to teach students how to effectively leverage AI tools, understand components of AI, where they may fail, how not to get yourself stuck in things like automation bias and other areas. Those are definitely going to fill the gaps for a couple of years until we might see even more profound shifts in this space. It's really hard, I think, to predict out what things are going to look, 5 or 10 years from now.
Yeah, couldn't agree more. Perfect timing on this question. How do you envision fast forwarding to 2030? What do you think is going to be different about working in the ED? I'm a solo on a night shift and I have all these potential AI tools. What do you picture being different about that? Or maybe not at all. Is there anything groundbreaking you envision being different for your average emergency physician on an overnight shift?
Yeah, I think my hope is that you won't have, again, you're not going to have to go and find information. The information is going to be presented to you. So all of that is going to be very accessible and you're not going to have to go data diving for various different things. My hope is also that we will see continued integration and augmentation when it comes to conversations with patients about prognosis and diagnosis, where you're getting real-time feedback from AI systems to help you make decisions collectively with patients about relevant aspects of their care. Could we see drastic change in the way things are? There may be population of patients handled almost exclusively through AI systems. We may move to a much more procedurally heavy emergency aspect of care delivery. So it's definitely a possibility as we move forward. One of the things that, it's kind of crazy because I thought it would have taken a lot longer, but there's definitely a shift within industry. You see it a lot within tech right now as like the advent of a lot of these AI agent systems, which is like an increased level of automation than I think we probably would have initially suspected. We're getting into this system where things are becoming much more goal-oriented. Example I like to give is think about a particular AI agent that its goal is to monitor or I guess since like managed patients like diabetes care. And so, it can order tests, it continually update and monitor the glucose values, arrange consult follow-ups and things like that within the system. I think we're going to see those types of tools. We're definitely seeing them in a lot of other areas in industry and tech. If you read recent headlines, tech with computer scientists are already starting to kind of, unfortunately, or it's maybe a product of the movement of tech in its space. We're seeing people lose their jobs because of the increased automation in that area. I think it's naive to think that process isn't going to happen in healthcare as well. We see it already a little bit on the administrative side with some of the billing stuff, but I always give the example of, it's going to take one healthcare system to take the leap and say, okay, now we're confident with the quality of the reads from an AI system for radiology. It'll be a snowball effect after that, right? Because the financial benefits are so profound if you eliminate 95% of your radiology workforce to an AI system that can read all the time and read it as fast as possible. We're getting closer and closer to those types of systems. Famous people like Jeff Hinton and Elon Musk had predicted that we would be at a particular point with AI usage with autonomous cars and everything else, and we're not there yet. They made predictions that was going to happen 5 or 10 years ago, but it does look like that's the trajectory we're moving.
Yeah, I'd say that if they were to make those predictions now, they might end up being right, but I guess that was kind of true then as well. You just gave us a real smorgasbord of opportunities. I would have settled for geographic patient locations. Just make the patient where the board says they are.
Where is the patient in the ED? I just want to find the patient and talk to the patient. Just show me where the patient is.
Spending 15 minutes out of every hour doing that.
One of the things we're very interested in at UVA now is integrating a lot of wearable technologies, and I think this has become even more feasible with AI. And so I think it's going to be the case that we change a patient into a gown laden with sensors and components, so we know exactly where they are, how they're moving, and their blood pressures on a continuous basis. We can have algorithms running on top of it. I think we're headed that way, and I think AI will help facilitate a lot of those things as well.
All right, so bringing back to today, what tools are you relying on every week, and how are you using it in your own practice or even outside of that?
Or research?
Yeah, I definitely use AI very frequently, more from an administrative writing standpoint, all the kind of day-to-day daily tasks and things. It's kind of crazy to think about going back without using AI at this point, because you can be so much more efficient in the way that you're doing things. I think where I'm really seeing profound opportunities is in the data analytics space. Some listeners may be familiar with some of these tools, but there's a tool called Cursor. OpenAI has another type of tool in this space. These are similar to that kind of AI agent we were talking about, where you effectively would give the tool a data set, and then you basically can interact with the data set in natural language and process the data set and however you want it. It's generating code on the fly, folder structures. It can build you out an app. As an example, I had this need to build out this power analysis calculator. We needed to test some of the parameters around that. Took maybe 10 minutes to build an app and deploy it on the web with these tools, which would have taken days beforehand, 600, 700 lines of code, and it was almost instantaneous. I say that because I think the research world is really going to change. Things are going to really start to accelerate. I actually don't think that we're prepared from a grant standpoint and funding mechanism standpoint to handle the kind of acceleration that's going to happen. It's going to be very easy to write actual grants, probably almost write grants at the click of a button with a key concept idea, and then have everything else just generated for you, which is really crazy to think about. But then ability to crank out tons of analyses very quickly, and how that's handled is going to really change. I don't know how that's going to change science. It could be that we become much more just AI. It's just AI cranking on AI to generate scientific ideas and concepts, and then it's passing on the synthesized abstract layer to us to try to understand. That seems weird, but there are already multi-agent systems that are out there discovering new things and able to write manuscripts and everything else. So it's not science fiction at this point. It's definitely there, and it's only going to get better as we move forward. But I definitely see that being incorporated more. We've started to train our admin staff to use AI tools, trying to get the rest of our staff to use it for various things, and our faculty to use it on a frequent basis. I see that we're going to see more and more of that as we move forward in the next couple of years.
I couldn't agree more. First and foremost, the IDE, the interactive developer environment for our listeners, is exactly what Dr. Taylor was just talking about. We've had a couple of guests on that kind of have taken coding into their own hands over time, but I think this is the first time people without any real background can walk up and start to try and wish a project or a model into existence. As long as you have patience and the ability to iterate, you'd be surprised at the things you can turn out. I definitely agree with that.
Yeah,
All right.
I think DJ and I are probably the biggest cursor addicts out there. I don't. I mean, it's
development is that Claude
Yeah.
Code has now obviated a lot of my need for
Yeah.
what I was previously
For
using Cursor. And so I
Yeah.
can just like load Claude Code into kind of terminal, and it works so much better without using so many of my tokens. There are a lot of tools figuring out for physicians what works for you, trying to get some physician-led design, or at least rush to an MVP that you can then turn around and say, is this something low-hanging fruit that we can target in our department? Is that a model that you would support, this chair, or is that something you're already promoting?
Yeah, I agree. And I think if we wanted to bring it back home, you really can think about ED operations leaders in the future having these tools at their disposal. So you no longer have to have 5 people building dashboards and environments. The ED operations person has a particular question or wants a particular viewpoint on something, and within a couple of seconds, some type of dashboard is built for them. All they've done is queried in a natural way to make that happen. I totally advocate for that moving forward. We should really think about systems that help us move that way. Another area we didn't talk about on the administrative side is policy documents and institutional knowledge, and having that at people's fingertips. One thing that we've done at UVA is to shift all of those policy documents, like the potassium 6.5, they have to go here versus there or something like that. And then all of the other kind of institutional, we just shifted all of those things into chatbots. So you just have to go to one place and you can just interact with them. Those types of things I think are just wonderful because it just cuts down on the amount of time you spend. And you don't have to worry about necessarily reading all the documents the first time around. You can just like, if that question comes up, I know where to go. So
Yeah, DJ and I have a lot to say about that. That's probably a whole other podcast episode, but we wanted to end there and just say thank you so much, Andrew, for joining us.
That's great.
Just amazing opportunity to talk with you. Such a leader in this space, and we just really appreciate your time. It's been an amazing conversation.
Yeah.
Thank you very much for having me.
Thanks so much. Come back anytime, and then we'll be following what you do.
Before we sign off, we're excited to announce something new we've added to our website. It's a voicemail feature. Head over to stataipodcast.com and you'll see a link to leave us a voice message.
Yeah, we're using SpeakPipe, and it's a tremendous application that allows you to leave a voicemail that we can feature on the podcast. And we do want to hear from you. So whether you've got questions about AI tools, want to share your own experiences with technology in your practice, or have ideas for future episodes, we'd love to feature your voice on the show.
Maybe you encountered an interesting AI application at your hospital, or you're skeptical about something we've discussed. Whatever it is, we want to hear your perspective. Keep it under 2 minutes. Tell us your name and where you're calling from.
You can find that on all of our episodes at stataipodcast.com. We're also on all the major podcast platforms, Apple Podcasts, Spotify, wherever you get your shows.
Thanks again for listening. Until next time, keep questioning how we use AI to make emergency better for everyone.
This is DJ Apakama.
And this is Ethan Abbott. Stay curious, and we'll talk to you next month. Thanks so much for listening to episode 15 of the Stat AI podcast. If you get a chance, check us out on X and Instagram and our newly updated website, stataipodcast.com. And make sure to tune in next month for some more amazing content. Thanks so much, and take care.
Please note that the views, opinions, and information expressed in this podcast are solely those of the individual speakers and do not necessarily represent those of their employers, our sponsors, or any affiliated organizations. The content provided is for informational and educational purposes and is not intended as medical advice. We encourage you to consult with qualified healthcare professionals for any medical concerns or treatment decisions. This podcast is not a substitute for professional medical advice, diagnosis, or treatment. Listener discretion is advised.